Hi, good afternoon, everyone. Thank you for your patience. I'm sorry that took a little bit of time to get everything together. We're going to go through a few cases today. I've got the wonderful Benny Samadi who's here, who's going to present a case. I'll kick off if that's all right, because I'm in the hot seat and my case is up. So this is a case who came through the unit last week. He is a 58-year-old gentleman with a background history of Hep C, IVDU, HIV, and heart failure, and severe diabetes. And he had a necrotic foot ulcer that required some resection. And then he starts to get MET calls for shortness of breath. Okay. So, well, Joe, do you want to start off with this one, if that's okay? Or should Joe Simpson? I'll try and start with the people who are sitting in the DDU, and then we'll go from there. Cool. All right, let's start off with this one here. So, Joe, when we're going through these things, we'll do it as if it is in we'll do it in a similar kind of way for the Vivers for the DDU. So it's relatively formal, but get to the point quickly, if you see what I mean. So you'll be shown about 5 pictures. There will be 6 cases or 6 to 8 cases in a 40-minute period. And we've got to get through all the cases. So the examiner may hurry you along. So the idea is a bit like a hot case where you've got to, get to the point quickly and efficiently. So I hope it comes through okay. Tell us what you think of this image.
It's a parasternal long axis view. The patient's a bit tachycardic at 101. The depth probably needs to be a little bit deeper so I can see what whether there's an effusion behind that pericardial and pleural effusion, but I can't see. I can see some B lines, so there's definitely some fluid in the lungs. And then looking at the heart, the walls seem to be contracting of the LV quite well. They're not thickened, but I'd have to pause and measure. The valves, the aortic valve and the mitral valve leaflets look thin. Can't see any thrombus or mass on the leaflets. I probably want to put some colour over that just to see if there's any regurgitation. The LA looks slightly dilated, and the RV looks of normal size. There's nothing really significant that I can see on here, just from this initial parasternal long axis view. All
right, what walls are we looking at? What wall's this and what wall's that? Oh, hang on, sorry, you got the wrong mouse. What wall's this and what wall's that?
So there's the posterior wall is the wall along the bottom, and then there's the intraventricular septum.
Yeah, and so if we're talking about segments, we're going to have, it's either the anteroseptal or infraseptal. Posterior, I think more commonly we talk about anterolateral and
anteroseptal at the top.
Beautiful. And infralateral.
And infralateral at the bottom.
Sweet. So I guess in the feedback, obviously it's constructive, and so hopefully, please, I hope I don't come across rude. So get to the thing a bit more. You're starting to talk about wanting to increase depth and pleural effusions. If that was the money thing, we'd show it to you in the exam, right? The big thing's going to be this guy's got what looks like a dilated left ventricle. You can see the marks down here. It's getting up to 6 centimeters and a bit, so it's dilated. We've got severe biventricular failure. So those are the things that I'd be jumping to. Is there a chronic component to it? Well, the left atrium isn't the size of the house, but it is certainly dilated, suggesting there may be a chronicity to it. And if this guy's horribly short of breath with diabetic ulcers, tell me what you're thinking. I mean, what's the story? Where am I going with this? Because the stem is really important. So he was lots of comorbidities, immunosuppressed, diabetic foot ulcers that required operation. So what are you thinking?
Well, he's got an element of heart failure anyway that we know about, and it's just whether he's got sepsis as a result of his necrotic foot and the bacteremia. So I'll be wanting to look at the valves to see if there's any lesions on the valves.
Very good, very good. And I guess the other thing, if we're looking at severe biventricular failure. And again, the left atrium not being the size of a house, because if you've got this bad systolic function, one of the questions may be, obviously we need other views, of course. I'm just suggesting, thinking ahead, are we dealing with a septic cardiomyopathy?
Yeah.
If someone's got a left atrium that's huge, that suggests chronicity. It's like the HbA1c of the heart. I love that saying. I didn't make it up.
Yes, it looks like it's acutely decompensated.
Yeah. Is there an acute component to it? And I guess this is important when you're getting to the end of some of these things, start talking about the management. You know, this guy's, if the right ventricle's down, we're obviously going to be worried to stick him on a ventilator. Are we going to be able to get him off a ventilator? Sticking people on ventilators with severe biventricular failure is fraught with danger. And trying to understand a chronicity or reversibility is really important. So that sort of comes through. I'm not suggesting for one moment that echo is perfect at doing this, but it's the kind of thought process that when you're doing the exam, try and get into, you know, because you've got to be at that sort of, you know, using the clinical information that you're given as well as the echo findings to try and decide on the management of a patient. You know, it's not just about reporting the echoes, it's about what you're going to do with the information once you've got it. All right, and this is important for the next bit. Okay, tell me about this one.
It's an apical 4-chamber. And you can see that the LV is globally down, systolic dysfunction and dilated. The RV doesn't look particularly dilated, but both atria are dilated mildly. I can see something on the mitral valve. I'm not sure if that's just the
yeah, and it might just be
muscles.
Yeah, don't focus on the mitral valve. It's all about ventricular function in this case.
So it's got global systolic dysfunction.
Yeah.
And it's dilated.
Beautiful. So again, just a little areas to think about would be talking about, and maybe this could just be me, and I'm sure I'm going to have people behind me smiling as I say this. I can't remember the exact phrase you used. I think you said globally down systolic function. Try and keep the discussion efficient. Yeah. So it's mild, moderate, or severely dilated. It's mild, moderate, or severe systolic dysfunction. So nothing's globally down. It's not mildly hypokinetic. You know, valvular dysfunction isn't mild or moderate. It's mild or moderate. Just to keep the discussion efficient, because efficient discussion makes you sound smart, I think. All right, so just get an idea about what we're seeing here. So this is a guy when he's not actually super unwell before he deteriorates. So this guy, then when we went to go and see him, and forgive me, I haven't been able to find the pictures beforehand, but he had a chest x-ray that showed some minor effusion on the left side, but otherwise relatively clear. He had pitting edema up to his neck, really amazing pitting edema up to his neck. He was a little bit short of breath. He had a lactate of 4, acute kidney injury, and a coagulopathy with an INR of 3. All right. And we brought him down to the unit and we had to intubate him. This was the only echo that we had. So of course we did it with some reluctance, one should say. We were not able to get decent views. So we went straight to a transesophageal echo. I might pick on someone else if that's all right now. You did great, Joe. Thank you. Lewis, hello, buddy. Are you?
Hello.
You're pretty good at toe.
No, definitely not. It's definitely a gap. So yeah, let's have a look.
Well, this is quite a tricky question then. Why don't I ask someone? Let me ask Anne-Marie. She'll be sitting there. So Anne-Marie.
Yeah.
And I'll pick on you guys some of the easier questions. I just want to start off with this one. So this is a great thing. So what view is this? Hatem, hey, this is Hatem's case that I'm stealing, by the way. So but can we please, well, thank Hatem for doing this, because we did this toe together and I think he did a great job. Was this a case study or a summative assessment that we did? Yeah, I thought you did a really great job with this.
Yeah,
I did have a look at that. I'm about to bring that up. Oh, fantastic! We can compare the Echo Fellows imaging. It's brilliant.
Transgastric. It's a deep transgastric.
Nice.
Which is
and
5-chamber, effectively. with the aortic valve on.
Fantastic. So, okay, we know we're in the deep gastric area. Just tell us why, sorry.
I can see the liver, the echogenicity.
Nice. We've got something up there that's looking through it. And if you're not looking at the left atrium, you've got to be gastric somewhere, right? And looking through this is clearly not atria. Beautiful. So this is the left ventricle that we've got here. There's your aortic valve that you're talking about. So what's that?
The right tricuspid valve.
No.
Oh,
What's sitting next to pulmonary valve? Because tricuspid valve doesn't sit next to it.
Yeah.
It's the pulmonary valve. Beautiful. Yeah. And so up here is where you've got the tricuspid valve. So this is, you get these quite unusual views. And Hatton, do you mind telling us how you got that view?
Oh, I was lucky.
You were lucky. I agree. And as soon as you put it up there, I thought, I can't wait to show this at DDU teaching.
Yeah, so I went with the deep gastric view and then did the maximum retroflexion that I can. Anti-reflection
yeah.
with, and then got the long axis, and then from that I turned 90 degrees and was able to get this view.
Fantastic. And you don't always have to go up to 90 degrees. Hatton did in this case. Like, you can find it closer to 0 sometimes. This guy had a bit of a rotated heart. And essentially, so this is a deep gastric view with a full anti-flexion. And often you then have to do full lateral movement as well. Okay, so it's taking both wheels and switching them in different directions, finding a way to hold them with one finger, and then just gently pulling back to try and get contact with the stomach. Certainly. Well, and maybe we'll do, maybe even next week we just, or maybe with the new fellows coming on, we're going to do a whole session just on transesophageal echo, and we'll go through a lot of the things. But the two wheels, the one closest to the probe does anti and retroflexion. The big wheel does anti-flexion and retroflexion, and then the wheel to the side moves it laterally, one way or the other. And we'll go through all of that in a lot of detail, maybe on a subsequent week. But for those doing the DDU, these are the kind of things that are more challenging to see if you know toe. We love challenging toe pitches because I feel if you know them, it's often a good example that you know echo. So just giving you an example of what we're looking at. That's got absolutely nothing to do with the case, however. All right, let's go for this one. So, Lewis, have a crack at this one. Tell me, let's just start off. So this is a toe image. Do you know what this one's called?
That's the mid-esophageal four-chamber.
Beautiful. So this one here is, what's that chamber?
It's left atrium.
Beautiful.
Yeah.
So left atrium, left ventricle, right atrium. Now, what do you think about, so you saw the images beforehand with the apical four chamber. What do we think about this now? And how does it relate to the picture?
Yeah, I'd say the information's similar. My frame rate's about 4 per second. So, but they're both dilated. So clearly, biventricular failure. The right ventricular wall looks like it's maybe, well, it's not thinned. So this again still looks acute. I'm trying to see more about the apex, which is foreshortened, but I think the apex is really moving good, as much as the rest of it. So it looks truly global. And that's about all I can say right now.
Nice. I'll try to maybe fill in a few gaps. I do apologize, the frame rate's not magic. The comparing these two images, one of the things that we found striking was that the right ventricle looked a lot bigger on this than it did on the transthoracic views. And again, if you remember, this guy's got a relatively clear chest x-ray. And certainly, I guess, with fluid up to there, you'd expect a bit more shortness of breath, and you'd expect pulmonary edema if this was all left ventricle. And when we were doing this one, our worry is, of course, about the right ventricle. So again, remember I said that this guy wasn't horrifically short of breath. He was very delirious and a little bit hypotensive, but he had a coagulopathy with an INR that was up, a bit of an AKI. He had fluid up to his eyeballs, and a relatively clear chest x-ray, and lactate that was raised. And all of that starting to point to, oh, this is the right ventricle that's maybe at play here. And if we have a look a little bit further up, you can see the right atrium. And again, it's tricky comparing transthoracic with toe, but the right atrium looks enormous in this. And one of the big things, which again, I think Hatton did really well in this study here, was picking up the extent of this tricuspid regurgitation. So tricuspid regurg is hard to look at in toe, and as is the right ventricle. And I think the right ventricle assessment is often quite a subjective thing with toe. Talk to me, maybe I can ask, I see we've got Danielle online. Danielle, are you able to tell me what are the other toe views that are really great for looking at, is she online?
Hello, yeah, I'm here, yep,
Right.
hello.
What are the toe views? What are the best toe views for looking for tricuspid regurg? Because Hatton and I saw this, and we thought this was indicative of severe tricuspid regurg. But again, it's a bit hard to see. We haven't got the best angle. I want to do Doppler analysis. What view can I do Doppler analysis of the tricuspid valve on toe?
So you probably won't get a very good Doppler analysis on the midesophageal four chamber because your TR jet is probably not going to be parallel to the ultrasound beam.
Excellent. Can everyone understand that? If I just put down that's completely correct. If I was to put down a line, I don't know, how do I do that? You know, if you can imagine I don't know how to do it. If you can imagine a line down there, the Doppler angle's off by about 90 degrees. So completely correct. Yeah, nice one. So what view do we have a nice angle on?
So sometimes it varies from patient to patient, but if you swung around to like a short axis view on the aortic valve and got your kind of wraparound RV inflow outflow view, you may get a better angle using that. Or sometimes also a modified bicaval view, depending which direction the jet's going. If you get lucky, you might just get it at the right angle there, at the correct angle. You don't want it at a right angle, you want it at a parallel angle.
And that's what we were trying to do up here. So this is a bit of and again, it's not the most perfect example in the world, but this is a modified bicaval view. So the bicaval view is, Anne-Marie, 110 degrees looking to the patient's right. So that's where you have the IVC coming in the left of the screen, the SVC coming in the top, left atrium at the top, right atrium underneath. And then you switch around to maybe 90 to 100 degrees and you get this view down here of the tricuspid valve underneath, and the tricuspid regurg is then coming towards the probe. And this is where you get the best view, I guess you can in these patients for the tricuspid regurg. So Joe, let's come back to you. So Joe, we were worried about severe TR on this thing, on this guy. So, and we were worried about significant pulmonary hypertension potentially. This guy's only got peak pressures of 14 millimeters of mercury here. So that's not pulmonary hypertension, right?
But he's got right ventricular failure probably,
Good.
so he's not going to be able to generate the pressure gradient.
So does he have severe TR then? So if you can't tell me about pulmonary hypertension, can you tell me if he's got severe TR?
Well, there's, looking at this picture here, there's the envelopes are complete. Whether there's any notching that you can get with when you look at the TTE, I don't know if it's the same with toe.
Sorry, notching of the what? Of the tricuspid regurg jet?
Yeah.
Hang on, notching is a little bit different. Yeah, the flying W sign. What's the flying W sign seen in it? So the flying W sign's on the pulmonary, on the RVOT. I'll pull this back again. This isn't the best picture. I think Adam did a pretty good job. So this was in that weird view that we were talking about at the beginning of the toe, when we tried to put our gate through the RVOT, so just before the pulmonary valve, and you're looking for the notching is in the forward flow coming out of the pulmonary valve. You get a kind of notching. It's sort of seen here, probably best on that view there. So during systole, as blood is coming out of the pulmonary valve, you get a notching, and that's with pulse wave Doppler in the RVOT. So not with tricuspid regurg. So stick with it. You said you got an envelope that's filled in the tricuspid regurg. Yep. So envelope filled in, so thick, lots and lots of blood flow around. So everything's yellow in there. Yep.
And can you look at the hepatic veins?
The one other view you might get is what's known as a cutoff sign, whereas if it looks like a V, that's indicative of severe TR, which this guy didn't have. So we went hunting to go and try and find the hepatic vein. And it's not easy on toe, I should say, but I think this might be a suggestion that we're getting there. I don't think we quite see what we've got, but I think there is systolic blunting. You know, during systole, I think you'd expect to see an S wave, which would be high, then a D wave, then the A wave reversal. And I think we've lost that. So I think this is indicative of severe TR, and we're trying to look at the hepatic veins. And we tried it again. I've normally found it sort of close to 90 degrees when you're in the deep gastric view and look around to the right. So I guess just to pull that all together. So we had a guy that had clinical signs of RV failure on a toe. It certainly looked like he got a bigger RV. It's not working properly, massive RA. And the big thing that was a worry for us was this severe TR, because if you don't do something quickly for these guys, they will spiral and they will die. And so rapid pulling off of fluid is the way to go. And I think we ended up taking off about 21 litres over 4 or 5 days of this guy. And he got echoed again by Anne-Marie today, which is very cool. And I just want to show you, oh, maybe, hang on, I might be able to do something. Let me just try something here. You got it. So let's find, let's do that one and that one. So this is the toe image in, oh, that doesn't work well at all.
The different cycle lengths.
Yeah, oh. I wonder if I can just make that one big and then try and go. So this is the toe image that you just looked at and reported on there, Lewis, where we can see this massive right atrium with the intratracheal septum pushed over to the left. And this is a right ventricle that is not contracting well at all. There's no bellows function in there. And comparing that to this one that was done today, I think we can see that this is contracting. That right ventricle is certainly contracting better. We've got better movement of that annulus, and the interventricular septum isn't pushed over quite as much. So it's showing the improvement with diuresis in the right ventricle function. And most importantly, there was improvement in the tricuspid regurg. Because you imagine if you stretch open that annulus and you get more and more regurg happening, you can get into a vicious cycle. So by making that RV smaller, you reduce the TR and reduce the stress on the right ventricle. Okay. I was only meant to talk about 15 minutes there, but I started talking about the right ventricle and went on for half an hour. So